In myopathy, the muscle fibres shrink down, and if we just draw this pictorially, imagine this is our field of view. This is the normal side where you've got nice, large, healthy muscle fibres, like so. And on this side, we've got small, shrunken, diseased muscle fibres. Imagine we put our concentric needle electrode over here. In its particular field of view, it will be able to pick up lots of motor unit activity. Because the fibres are shrunken and small, they can only generate very small amounts of current. Hence, what we are going to find are small polyphasic units on our oscilloscope, so they'll look like this. This is in marked contrast to the situation in the normal muscle fibres, where we're only able to pick up a couple of motor units and they're all generating reasonable amounts of electrical activity. So that's what we would normally see. So in a normal situation with a normal muscle, we're able to pick up with a green concentric needle electrode between 5 and 7 muscle fibre activities, and they'll summate to this motor unit action potential like so. In the disease state with myopathy, we're going to pick up lots of small motor unit action potentials which look polyphasic as opposed to this large motor unit action potential. We are then looking at how the muscle generates force. So in this normal situation, we've talked about the Henneman principle. We are increasing the frequency with which the motor units are recruited, and then the size and the amount of the motor units recruited. In myopathy, the brain is telling the muscles to squeeze, and because it's not generating the amount of force that the brain is trying to generate, because the muscle fibres here are small, they're shrunk and they're not working right, lots of these motor units are going to be activated because the pathway between the brain and the muscle is unaffected here. Lots of signal driving the muscles to squeeze is going to occur, and so we're going to be driving these small shrunken muscle fibres as hard as possible in order to generate force. Because they're also small and they're so weak, they're not going to be generating that force, but it's going to be the equivalent of the brain whipping the muscles into a frenzy to try and generate the force necessary to activate the movement. Hence, when we're looking at how the motor units are recruited, they're not recruiting like in the Henneman principle. Rather, what's happening is very, very rapidly we are going to get lots of activity that just fills up the screen very quickly. And this is called early recruitment, and we're seeing small polyphasic units. The other thing with myopathies that we're looking for is what happens when we're sticking the needle in. Is there irritation of the muscle membrane? And we can pick this up in a number of ways, and we can see fibrillations, positive sharp waves, complex repetitive discharges, and these are all features of myopathy. And some of the more chronic myopathies, we can also see what's known as muscle fibre splitting, and here we will start seeing some neurogenic changes present as well. I'm going to show you a great example of a myopathic muscle, and the first thing you're going to hear is actually a burst of complex repetitive discharges here. So the needle's just gone into the muscle, and you're now going to see what's happening. Not only are there CRDs, there are also some fibrillations here as well, and I'm now going to show you the motor units too. Here you can see small motor units together with the fibrillations, and the patient here is at rest, And if you contrast that to my recordings, there are quite a few muscle units present from the very get-go without the patient having to do anything at all. Here the patient is barely activating their muscles, we're having small units, they sound very scratchy, they're coming in very rapidly. These are very typical findings for a myopathy.